Assalamu alaikum wa rahmatullahi wa barakatuh. Good evening, everyone. Welcome you all to our fourth and last Young Leader Forum for the year 2021. The theme for today's symposium is endocrine disorders in women, and we will be having three talks, which will be interesting. Before we start, we would like to extend our thanks to the unrestricted educational support from Servier for continuously supporting this activity. Also, there are some housekeeping points that I need to announce. First, this webinar is also live streaming in the Society YouTube channel, EDES YouTube channel. And it will be available on-demand webinar sections in both the Society website as well as YouTube channel. We encourage you all throughout the presentations to place your questions in the Q&A box. And please do mention the speaker name to whom you are directed the question at the beginning. If you have any issue during the presentations, you could have a live chat with our team through WhatsApp on the displayed number. And we are happy to announce that this activity is accredited 1.5 CME hours. So without further delay, we will start our first presentation. And the first talk is Approach to PCOS Diagnosis and Management. And our speaker is Dr. Asma Al-Jabari. Dr. Asma is a consultant endocrinologist at Tawam Hospital. She completed her clinical and research endocrine fellowship training at the division in USA, and her main area of interest is around osteoporosis, hyperlipidemia, and metabolic disorders. Dr. Asma, you can share your presentation, already it is displayed, and you can start.
Thank you, Dr. Raya, for the kind introduction. I'll start my presentation. Today, I'm talking about PCOS. I don't have anything to disclose. My objectives for tonight to describe the endocrine pathophysiology of PCOS, understand the different consensus criteria for the diagnosis of PCOS, discuss the associated hormonal, metabolic, and other disorders that accompany PCOS, and outline the treatment strategies for women with PCOS across the lifespan. What is PCOS? PCOS is a complex disorder affecting women of childbearing age characterized by increased androgen production and ovulatory dysfunction. It is the leading cause of an ovulatory infertility and hirsutism, and women who has PCOS has increased risk of miscarriages, insulin resistance, hyperlipidemia, type 2 diabetes, cardiovascular disease, sleep obstructive apnea, and endometrial cancer. The first identified syndrome was in 1935 by two physicians named Sten and Leventhal. They were the first one who described a group of women who were obese and infertile with enlarged ovaries and multiple cysts. And that was the first description. Later in 1990, the same syndrome was changed to be called Polycystic Ovarian Syndrome. PCOS prevalence depends on the criteria we're using to diagnose the patient. So if you're using the NIH criteria, the prevalence is 6 to 10% of reproductive age women. While if you're using the Rotterdam criteria, the prevalence increased to 12 to 20% of women at the reproductive age. Talking about the PCOS prevalence in symptomatic women, so 87% of women with oligomenorrhea has PCOS. 26% of patients with amenorrhea has PCOS, while 92% of women with hirsutism has PCOS, and PCOS present in 90 to 95% in infertile women. What is the characteristic of this syndrome? Usually it presents with menstrual irregularity, and this could be that from the start after menarche. So the patients might have the first menstrual cycle, then irregular from the start. Or adolescents might have a delayed in the onset of their menstrual period. or some of the patients will have a breakdown of a previously regular cycle. So if the patient is having less than 9 menstrual cycles per year, or there is no menstrual period for 3 months or more consecutive months, we can label them as having a regular period. And usually an ovulatory is the results of infertility in such women. The other characteristic is hyperandrogenism. So hyperandrogenism women will present either with hirsutism, acne, or male pattern balding, or male distribution of body hair. And there is also a reproductive sequelae of the PCOS. So there is different degrees of infertility on such women. PCOS is the frequent cause of an ovulatory infertility in women at reproductive age. And women with PCOS will be less responsive to therapy to induce ovulation and conception. The hormonal abnormality on PCOS, if you're going to do the labs, you will see elevated of LH, increase the ratio LH to FSH ratio, elevated androgen levels, or decrease 6-hormone binding globulin. And there is also metabolic abnormalities in this syndrome. And the main driving metabolic abnormality is the hyperinsulinemia and insulin resistance. And it is independent of the effect of obesity. The decrease in the peripheral insulin sensitivity and the consequence hyperinsulinemia may play the important role in the pathogenesis of PCOS. So what is the etiology of PCOS? There are many theories around, and most of them describe that there is an interaction between genetic factors, endocrine factors, metabolic factors, neurologic factor, and environmental factors. So if we're looking at this graph to know more about the pathophysiology, there are mainly 2 driving factors. First of all, the abnormal GnRH pulsation. So those kind of patients will have abnormal GnRH pulsation with the increase of the GnRH, leading to the increase in LH secretion, amplitude, and pulsation. And that increase of the LH will work on the theca cells in the ovaries, leading to increase of the follicular size and number. But at the time of the selection will lead to arrest of the selection. So that will lead to polycystic ovarian morphology and will lead to an ovulatory in this patients because of the arrest of the selection of the ovaries. And at the same time will cause hyperandrogenism and increase the adrenal androgenism. So that will decrease the negative feedback to the hypothalamus and pituitary. And with the increasing the negative feedback, will continue having more GnRH secretion. On the other side, those patients, as I said, that they're having increased insulin resistance, which is irrelevant or independent from obesity. So they will have increased resistance to insulin in their muscles and liver, and they're having also adipocyte dysfunction, leading to hyperinsulinemia. And hyperinsulinemia will work in ovaries again, and that will cause increase in the secretion of androgen and steroidogenesis. At the same time, the whole process, both of the increase of the LH and hyperinsulinemia, will also cause the follicles to be more resistant to FSH and increase more AH hormone. How we're diagnosing PCOS? So we'll go through this case first. A 19-year-old woman presents with hirsutism, acne, irregular period since menarche at age of 11. She has increasing hair on upper lips, chin, but no male pattern balding. She has had difficulty losing weight with diet and lifestyle intervention. In the last year, she has had 3 cycles and another with a progestin withdrawal. On examination, she has an anabolic appearance, BMI is 29, excess hair on lips, chin, neck, and no temporal recession, no clitoromegaly, and grade 2 acne. On timed blood, day 1 to 5, after an induced menses, her LH was 15 and FSH was 5. Testosterone is 70, higher than normal. Normal was 40. DHA is 400, slightly elevated, and hemoglobin A1C 5.5. And this is a poll question, and I need your answer. What do you think? After inclusion of other endocrine disorder. Which of the following is the NIH consensus criteria for the diagnosis of PCOS? High LH-FSH ratio, clinical biochemical hyperandrogenism and multiple cysts in the ovaries by ultrasound, abnormal weight gain, clinical and biochemical hyperandrogenism and multiple cysts on the ovaries by ultrasound, or clinical and or biochemical hyperandrogenism and oligoanovulation, or multiple cysts in ovaries and the clinical or biochemical hyperandrogenism. What do you think? We'll give you a few seconds to answer. Can you show the results of the polls? Okay, so most of you choose A, high LH-FSH ratio and the clinical, and the answer is C. And now you will know why. So there are three main criteria to diagnose PCOS. It's either NIH or Rotterdam or androgen excess polycystic ovary syndrome society criteria. So NIH mainly depends on two criteria, and both of criteria needed for diagnosis: hyperandrogenism and or hyperandrogenemia. That's mean either clinical or biochemical with oligoanovulation. While the Rotterdam criteria need 2 out of 3, clinical or biochemical hyperandrogenism, oligoanovulation, polycystic ovaries. And we can discuss later the polycystic ovary criteria of the ultrasound. So it should be based on the Rotterdam criteria. Ultrasound should show in those women a number of 11 follicles in either ovary, and the size should be between 2 to 8 millimeter. Or the patient, one of the ovaries volume should be 10 or more ml. These are 2 out of 3. And the androgen excess polycystic ovary syndrome society criteria need both of these criteria: hyperandrogenism, clinical and or biochemical, ovarian dysfunction, either the anovulation or the polycystic. So if we're going to the question, they want the NIH consensus, and the high FSH LH is not part of any of the criteria. Abnormal weight gain is not part of any of these criteria. Multiple cysts on ovaries and the clinical or biochemical, this goes with Rotterdam or the excess androgen, but the clinical and biochemical hyperandrogenism and oligoanovulation is the NIH criteria. If we're talking about Rotterdam criteria, it is the most commonly used nowadays in many parts of the world, and the patient's phenotype divided in 4 types. If you can look at these circles, for example, if this is hyperandrogenism and this is the polycystic ovarian morphology, and here we're talking about oligomenorrhea, type A morphology, patients will have 3 of the phenotype, while type B will have only oligomenorrhea and hyperandrogenism, and this is we call them type B. Type C will have polycystic morphology with hyperandrogenism, and type D will have oligomenorrhea with polycystic ovary morphology. The importance of having phenotypes will help you to manage those patients and to know which medication you need to start them on. There is few challenges in diagnosing adolescents with the PCOS, and this is mainly because menstrual cycle during adolescence have a physiologic variability and reproductive and hormonal fluctuation in that period of time. And most of them, around at least, not most of them, 26% of them will have multifollicular ovaries at that age. And it is normally at this age to have ovarian volume bigger than later in life. So if the patient is having 2 years after menarche, typically age of 14 to 19, with a period of a prolonged amenorrhea, has been found to be the predictive of persistent ovarian dysfunction later in life. So to diagnose a patient with polycystic ovarian during adolescence, patients should have high serum androgen level and or progressive hirsutism in association with persistent oligoamenorrhea for at least 2 years after menarche, and or primary amenorrhea by age of 16, or ovarian volume more than 6 centimeters cubic. And this is for sure after exclusion of secondary causes. Let's go to our second case. 23 years old white woman presents with irregular period for many years. Her periods are unpredictable and typically occur every 1 to 3 months with a variable menstrual flow. Her last menstrual period started 2 to 3 months ago. She denied excessive hair growth or abnormal acne, and she denies historical elements that would suggest estrogen deficiency, reduced energy availability, or excess psychological stress. The patient is overweight, BMI is 27, and she doesn't have clinical hyperandrogenism by physical exam. A pregnancy test, prolactin, TSH were all checked 2 weeks back by her PCP, and results were remarkable. The bullet here about what is the most appropriate next diagnostic step: to do serum-free testosterone measurement, assessment of ovarian morphology by ultrasound, checking anti-Mullerian hormone, assessment of mid-luteal progesterone level, and early morning follicular phase 17-hydroxyprogesterone measurement. What do you think? What you would do next? So just to go, remember that this patient is having these things: irregular period, and she denied. So most of you chose 32% for assessment of ovarian morphology by ultrasound. And the correct answer actually, serum-free testosterone measurement. If you remember, if you're going to the diagnostic criteria, patients, you should, to diagnose them with PCOS, you need to diagnose hyperandrogenism and irregular cycle. So this patient is already having a regular cycle, and she denied clinical hyperandrogenism. Now you need to investigate her if she's having biochemical hyperandrogenism. So the first step, you would need to do free testosterone to check if she's having hyperandrogenism biochemically. So if you did free testosterone and the patient is having a regular period, by this, you diagnosed the PCOS by any of the diagnostic criteria, and you would not need to do the ultrasound. Regarding the 17-hydroxyprogesterone, we not yet diagnosed the patients with hyperandrogenism. So if the patient diagnosed already with irregular cycle and hyperandrogenism, then we would think about non-classical congenital adrenal hyperplasia, and we would do the 17-hydroxyprogesterone. So this step is not yet due to be done. Assessment of mid-luteal progesterone levels. This is done in female who's having hyperandrogenism, polycystic ovary, and morphology by ultrasound, and but have a regular cycle. So we need to do mid-luteal progesterone to check if this patient is having an ovulatory cycle. She might be menstruating, but she's not having ovulatory cycle. At that time, you need to do mid-luteal, but this patient is already having a regular cycle, so you no need to do it. Anti-Mullerian hormone is not really needed to diagnose a PCOS patient. Okay, so when you need to, should worry about the hormonal disorder. So if the patient, your patient is having hirsutism, Akantosis Negriskans, and she's having oligomenorrhea, or the patient is also having virilization, like deepening of her voice, clitoromegaly, increased muscle mass, or decreased breast size, you really need to worry and do endocrine workup for this patient. And put in your mind that virilization is really a sign of androgen secreting tumor, and it is not a sign of PCOS. So what you need to do: testosterone first. Number one, biochemical labs you should order, and mainly you can calculate the free from the total, but if you're having a chance to do the free testosterone and you're having it in your reference lab, would be better to do it. 17-hydroxyprogesterone to have the differential between non-classical and the PCOS, then you can do the ultrasound. At the same time, you should do other labs to exclude other endocrinopathy like DHAS. If the patient, you think that she's having virilization, TSH, prolactin, androstenedione, LH, FSH ratio, it would be helpful, but it is not necessarily to be done. 6-hormone binding globulin, also it's going to support your diagnosis if it is done, but again, it is not part of the lab must to be done. So if you diagnose your patients with PCOS biochemically, with clinically and the biochemical lab, then most likely this patient is having PCOS. At that time, you need to evaluate them for metabolic disorder. So in every visit, you need to check your patient BMI, you need to check the blood pressure, fasting lipid panel, fasting insulin, glucose, OGTT, hemoglobin A1C, and LFT. PCOS, when you're doing the hyperandrogenism workup, the results usually PCOS in 71% of your patients. And the tumors or in such patients is really very rare. Most of these studies show that tumor risk is 0.3% of those patients presenting with hyperandrogenism. So now we're moving to talk about the management of PCOS. When you're taking care of patients with PCOS, you should approach this patient holistically and make sure to assess all the problems rather than approach one problem by itself. And here, I came across a cross-sectional study, studied 134 women with PCOS with 198 controls without PCOS to evaluate their healthcare providers. Those patients found that they're having a less trust in their PCP, and they perceive them as less qualified to treat PCOS-related health concerns and argue with them more often. And this is giving you that the importance to have how to counsel those patients and to approach them at different aspects affecting their life. When you're having the patients, you need also to approach the patients to know what is concerning the patients more at this stage of her life. For example, is it fertility, hirsutism, acne, obesity, irregular periods, or all of the above, to decide what you need to treat first. And now we'll go to talk about specific management of such patients. So we'll talk first about this patient. She's a 15-year-old girl, presents with amenorrhea, hirsutism, and acne. She underwent puberty at age of 9 with axillary and pubic hair development, hilarchy at age of 10, and menarche at age of 13. She never had another menstrual cycle. She's most concerned about the hair growth and acne, which have developed over the past 2 years. She has been overweight since age 9. Physical exam reveals blood pressure normal, BMI for age percentile 92, mild acne, Akantosis Negriskans, Fermin-Galway score 10, Tanner breast stage is 5, Tanner pubic hair stage 5, labs normal TSH, normal prolactin, FSH 6.7, LH 14.3, total testosterone 64, slightly elevated, 6-hormone binding globulin at a lower level, DHAS normal, glucose 2 hours post OGTT is normal, beta HCG is negative, ultrasound transabdominal reveals ovarian volume of 17 in the right and 14 in the left, normal uterus with 5.8 thickness. So you diagnose this patient with the PCOS. The question is now, what treatment will be best target the symptoms of concern in this adolescent patient? Combined hormonal contraception, metformin, spironolactone, diet and exercise, or hydroxyprogesterone. Can you show us the result, please? So most of you chose the correct answer. So the correct answer is combined OCP. And we would know now why. First of all, many studies have been done to assess the cutaneous signs of PCOS. In a cross-sectional study, they found that 401 women suspected of having PCOS. underwent extensive skin exam by dermatologists. 92% of them, they were having a skin finding. And acne was found on most of those patients, and 61% of the patients with PCOS, and it was mainly at the face trunk. You should know that, acne is not a specific for PCOS. And when they did that study, they didn't find any systemic association and didn't have significant quality of life impact for the patients. While hirsutism is the specific sign of PCOS, usually we're using the modified Fuhrman-Galloway score to score the hirsutism in such patients. This score is studying 9 body sites, and it is a visual scale between 0 to 4. Total scores is 37, and the patient's hirsutism degree based on their results, like mild, moderate, severe. And if you remember that our patient was having a score of 10, so she was having a mild hirsutism. Hirsutism found to be in 70 to 80% of patients meeting the criteria for PCOS, and it is always once diagnostic evaluation. And you should also bear in mind that even if the patients in Fuhrman-Galloway score is having a lower score in Caucasian and East Asian, that's still a concern, because those population usually they don't have hirsutism, and they're having a few body hair. And in general, the hirsutism increase in a darker skin. The more the darker skin, the more patient would have hirsutism. And you need to differentiate between villus and hirsutism, because there is a difference really between the patients who's having hirsutism, which is a thick terminal hair, usually more than 5 millimeter in length, dark in pigment, have a shape, modulated, while patients with the normal villus, it's usually less than 5 millimeter in length. It's uniform in shape, unmodulated, and might have a pigment or unpigmented. And hirsutism effect, in that study, they found it affect 53% of patients with PCOS, and it could be at any site of the body. And there is always a difference between how clinicians perceiving the hirsutism and how patients is perceiving the hirsutism. And patient rating best predict depression. So in that study, when they use different side index for depression, they found that the patients with hirsutism, they're having a higher rate of depression, and it was affecting their quality of life. Akantosis Negriskans is another skin manifestation in such patients, and they found that it affects 30% of patients with PCOS. It might present at different sites. It's not only at the neck, it could be axillary, it could be knuckles, it could be knees, elbows, everywhere. And it is one of the specific signs for PCOS, and it always have a metabolic association. What are the best management for such patients with hirsutism? So what you need to know that most of this is not FDA approved medication. And when you're treating with those patients, you need to know that prolonged more than 6 months, at least medical therapy is needed. And you should use effective contraceptive for contraception with anti-androgen in such patients. And if your patient is having mild hirsutism, OCP is the first line of a treatment. Spironolactone later, if the patient is having didn't respond to OCP, or in cases of severe hirsutism. Another anti-androgen medication like finasteride or flutamide is another choice in severe hirsutism, but you should know that they're having a major side effect like hepatotoxicity and category X side effect. And other treatment like topical laser is one of the things, topical anti-androgen, metformin, statin, and to decrease the testosterone level. TZDs also were studied and to decrease hyperinsulinemia, but with a limited evidence and treatment of PCOS. So PCOS is a common cause of hyperandrogenism, and in such patients, you really need to collaborate with your dermatologist in diagnosis of the skin manifestation, and for a better management also of their skin manifestation. Case number 4. So this is a patient, a 28-year-old woman with a history of irregular period, hirsutism, and progressive weight gain, would like to get pregnant and wants to know the best treatment options. PCOS was diagnosed at age 18, and she has been intermittently prescribed OCP and spironolactone for hirsutism. She weighed 63 in high school and now 72 in college, and her current weight is 82, and height is 160 centimeter, BMI of 31.9, blood pressure 130/80, urine pregnancy test is negative. She began metformin 6 months back, and her period have been more regular for the last 3 months. So which of the following treatment would be most effective in induction of ovulation? Letrozole, clomiphene citrate, gonadotropin, cabergoline, or progesterone suppository? So what do you think? Can we see the poll results, please? Clomiphene citrate. Okay, so most of you answered clomiphene citrate, while the most effective, based on recent studies, showed that the letrozole is the most effective. When they compared letrozole with the clomiphene citrate, they found that the induction is the same, but the rate of live birth with letrozole was better. So that's why, though clomiphene is the first line treatment, most of the recent studies suggesting or recommending to start with the letrozole if you want to have a better outcome with the live birth. So infertility first line, you should advise your patients with for weight reduction. They found that as minimum as 5 to 10% weight reduction would improve more than 50% of the ovulatory cycle. First line treatment triggers ovulation in 80% of the patients. Letrozole, clomiphene citrate, and metformin could be tried. Letrozole actually and clomiphene is the best in the induction of ovulation. Many studies have been done to study the metformin effect, and they found the metformin effect was better on young population, mainly in adolescents, to restore the cycle. And mainly it was due to the decrease in the weight and decreased the hyperinsulinemia, improving the 6-hormone binding globulin synthesis from the liver, and decreasing free androgen and restoring the cycle. The second line of treatment for those patients would be gonadotropin therapy, GnRH, as if the patients failed to have an induction with the first line treatment. A surgical procedure, previously, historically, they were using wedge resection of the ovaries if the patient is having really very large volume and multiple cysts. Laparoscopic ovarian laser electrocautery is another surgical option. And the last option is IVF. What if the patient is having the same patient is having menstrual irregularity, but she's not willing to get pregnant? So in this case, the most important is going to be to regulate her cycle to make sure that she's not having endometrial hyperplasia. So combined contraceptive, cyclic progesterone, or continuous progestin is another options for her. So last case is about 40-year-old South Asian ancestry diagnosed with the PCOS at the age of 27 when she presented with a delayed conceiving and oligomenorrhea. Ultrasound showed little follicles and enlarged ovaries, high LH-FSH ratio more than 3 times. She achieved successful induction of ovulation and hormonal and normal pregnancy after clomiphene treatment. Family history of a premature cardiovascular disease. Lipid panel showed high total cholesterol and low HDL. Had another child at age of 33 with a spontaneous ovulation. Currently complains of oligomenorrhea and facial hirsutism. Gained weight, BMI 28, LH-FSH more than 3 times. The ratio is more than 3 times, and slightly elevated testosterone. So this patient is already diagnosed with the PCOS. What do you think? Is this patient at a high risk of metabolic dysfunction and long-term health problem? Yes, for sure. And as we mentioned previously, that patients with PCOS, they're having a high risk for metabolic disorders. What additional tests you should be considered? So any patient with the PCOS, as I mentioned, when you diagnose them, you need to diagnose them for metabolic disorder. You need to check their BMI. You need to check their lipid profile. You need to do their hemoglobin A1C, OGTT at a different interval. You need to check their waist circumference in different visits to check if they're having an increase in their visceral fat also. All this should be done on regular visits. And the labs also, the labs for metabolic disorder should be done on a different interval. This patient is now having a regular period and hirsutism. What do you think? Is it reasonable to prescribe combined OCP for her to control her symptoms, knowing that she's having history of a premature cardiovascular disease in her parents? So we know that, if the patient's PCOS is really having a high risk for cardiovascular disease, and you need to decide who's going to benefit from PCOS and who might have the side effects of the medication. So studies showed that BMI more than 30, women with BMI more than 30, for mainly we're talking about DVTs, or also if the patient is having history of smoking or other risk factor for cardiovascular disease. So if you're going to start this patient, you need to monitor her closely and tell her about the symptoms of what she might have, or you need to follow her regularly to check for the side effect of the medication. How would monitor her progress? You will monitor this patient, as I mentioned, in different interval to check her response to the treatment, and at the same time to assess her metabolic disorder. And here a few slides about the insulin resistance on such patients. Since we're talking about metabolic disorder, high insulin level can stimulate androgen production in those women and stimulate androgen steroidogenesis by enhancing sensitivity of the adrenocorticotropic hormone. The association between weight gain and PCOS, they found that more than 50% of the patients would either be moderately obese or having overweight, and usually it is android type of obesity with high waist to hip ratio, and those patients, obesity will worsen their insulin resistance and they're increasing their cardiovascular risk. Regarding the lipid and the lipoprotein abnormality, they would have high LDL, high triglyceride, decrease HDL, and decrease apolipoprotein A, and impaired fibrinolytic activity. We mentioned that she's coming from South Asia ancestry, and here there is a big study done to assess the patient's impact of the race on the metabolic risk. And they found that, for example, here, a US Black American, they were having a high risk for metabolic disorder, higher BMI, and blood pressure with a low HDL, while Indian, they were having high TG and glucose were impaired and HDL were high. There is also another study done to assess family members of patients with the PCOS to assess their risk for metabolic risk, and they found that there is a genetic disorder on those patients, and it is not only a female disorder. The family members will have also that genetic disorder. Mothers will be more having more risk to have metabolic disorder, dyslipidemia. Father will have metabolic dyslipidemia and hypertension. Brothers found to have more hypertension, and sisters, they will have hypertension and metabolic. And this is based on a large study done to assess the genetic risk in patients with the PCOS. Another study, large study done on 1,123 females to assess their risk of coronary artery calcification, found to have a higher risk of calcification. And I already mentioned this is the metabolic screening for patients to prevent their cardiovascular risk. And the goal is really to assess the risk for patients with PCOS and to start screening them earlier and start the treatment as early as possible with weight management, diet. If you can start them in metformin or any other medication can help them with the weight loss, like orlistat, GLP-1 agonist. And if they're really morbidly obese or with a high risk, you can send them for bariatric surgery. Metformin showed that. Metformin showed that it improved the weight circumference and it improved the testosterone FSH/LH, but didn't have much effect on the total cholesterol, 6-hormone binding globulin, TG, and the limitation of that study, variable dose of the metformin, and the duration of the study. So when you start metformin, metformin should be started for the treatment of weight and hormonal metabolic outcome. Mainly it was found for patients when they're having a BMI more than 25, and it was shown more effective in adolescent patients. And by this, I'm coming to the end of my presentation, and this is only a summary of the presentation. PCOS is a disease with multiple endocrine disorder, and there is multiple causes for this disorder. And to know how to target the treatment, we need to study our patients very well to know what is bothering them and target the treatment and approach them holistically. This is the list of my references. Thank you for your attention, and mic back to Dr. Araya.
Thank you, Dr. Asma. Thank you for the extensive review. So our next speaker is Dr. Badur Al-Imadi, who will give us a talk on a primary amenorrhea case approach. Badur is a consultant endocrinologist in Dubai Hospital. She had her fellowship training in endocrine and diabetes in King Faisal Specialist Hospital and Research Center in Riyadh, Saudi, KSA. Also, she is American Association of Clinical Endocrinology ultrasound, neck ultrasound, she holds the certification for neck ultrasound, and also she holds the UK specialty certificate in endocrine and diabetes. Dr. Badur, welcome, and please share your presentation.
Thank you, Dr. Raya, for your kind introduction. So today I'm going to present primary amenorrhea case approach. I have nothing to disclose. My objectives for tonight, I'll be speaking about normal puberty physiology, what are the pubertal markers and timing, past history of puberty, some definitions, then we'll move to delayed puberty causes, then primary amenorrhea evaluation, and finally the differential diagnosis for primary amenorrhea. So we have here a 15-year-old female referred to the endocrine service for primary amenorrhea and delayed puberty in 2018. She attended the clinic with her father. He mentioned a possible remote history of minimal PV bleeding before getting sick. There's no such family history of delayed puberty. Review of system was unremarkable. She was an average student with unremarkable obstetric history with a normal development of milestones. She had a past history of acute myeloid leukemia, diagnosed in 2015, received high-risk protocol chemotherapy. She went into remission the year after. On examination, she was normotensive. She had a height of 166 centimeters, matching her mid-parental height. Her Tanner stage breast was 3, and pubic was 3, with a normal external female genitalia. There was no excess of hirsutism, and she had a female body habitus. There is no any palpable masses in the abdomen, and there was no physical stigmata of Turner syndrome. So in summary, we're having a 15-year-old lady, breast Tanner 3, pubic Tanner 3 with no menses. So is this delayed puberty, or this is stalled puberty? Is this primary amenorrhea, or still premature to say that this is primary amenorrhea? So let's go first to basic science. The pubertal physiology in female is composed, in general, the puberty have two components. One is the gonadarchy, and the second is the adrenarchy. The gonadarchy involves the activation of the gonads by the pituitary gonadal axis, that is the LH and the FSH. And the adrenarchy is an independent process of the gonadarchy. It doesn't depend on the pituitary gonadal axis. It depends on the production of the adrenal androgens by the adrenal cortex. And this is manifested on skin. You can see the acne. The epicrine gland will start to make the adult type body odor. Then there is the pubic hair development that is followed by the axillary hair development. So the first pubertal marker is telarchy, which is the breast development, and is strongly determined by genetics, BMI, nutrition, and health. If we go back to the history of puberty, in mid-19th century in Europe, the menarche, the onset of menarche was at age of 17 and 18 years of age. But toward the end of 19th and century of 20, there was a decline in the age of the menarche, and this is attributed because of the better socioeconomic status. Now, the definition of delayed puberty, when we say delayed puberty, usually when we say delayed puberty, we are referring to the gonadarchy component, not the adrenarchy. So delayed puberty means delayed gonadarchy. And it's the absence of the secondary sexual characteristics that suppress development by 2 to 3 standard deviation above the mean age for that culture. For example, in US, and as well the same applies here in UAE, absence of breast development by age of 12 in girls and boys. It's called delayed puberty when there is absence of testicular enlargement by age of 13. Stalled puberty, as the word refers, it means the secondary sexual characteristics have developed, but they have not completed within 4 years. The whole puberty signs should complete within 4 years. So this is stalled. Primary amenorrhea, there are 2 definitions for primary amenorrhea. One is that by age of 15, this is the time that you're expecting the menarche, there is no period in the presence of breast development, because usually the breast starts around age 13 and within 2 years, they have the menarche. So there is breast, but at age of 15, not yet, they have the menarche. Or at age of 13, when you are expecting the development of breast, there's no breast and there's no menarche as well. If we go to the delayed puberty causes, we can categorize them into broad categories. Now, the commonest is the constitutional delay of growth and development. This is more than 50% of the time, this is the diagnosis. The other causes could be divided into functional, hypogonadotropic hypogonadism. These are they are delayed, but then there is a spontaneous recovery. So when we say the word functional, we mean either because of excess dieting or because of excess exercising or because of a sickness that is uncontrolled. For example, type 1 uncontrolled, celiac uncontrolled. All these can lead to a functional hypogonadotropic hypogonadism. Other category are central causes, hypogonadotropic hypogonadism. Third category is at the level of the gonad, permanent hypergonadotropic hypogonadism, and there are other etiologies that have no clear classifications. Okay, so now our case is she's at age 15, no yet menarche, and she has a breast development. So we are dealing with a primary amenorrhea. How do we evaluate for primary amenorrhea? There is a very long list of workup that you can do, but here we will focus on the essential one that will direct your pathway later. So definitely any lady presenting to me with primary amenorrhea, the first thing I would like to rule out pregnancy. Now, 2 very major investigations. One is biochemical and the other is radiological. The biochemical is the FSH to guide me whether I'm dealing with a gonadal cause or at the level that is central. Then the radiological essential investigation is the uterus imaging. The rest of the workup is the same when you're working for secondary amenorrhea. Any etiology that can lead to secondary amenorrhea can always present as primary amenorrhea, like thyroid dysfunction or hyperprolactinemia. So let's go through this pathway. In this pathway, we are starting with the uterus. If the uterus is present, we look at the FSH, if the FSH is high or not high. So just before going through this diagram, just to let you know that there are two strong indications that push me to do the karyotyping when approaching primary amenorrhea. One, radiologically, if I have an absent uterus. Second, biochemically, if I have a high FSH. So these two, if you found any of these two, you have to go by default for karyotyping. So when the uterus is present, if the FSH is high, as we said, we should go for the karyotyping. So we have three differential diagnosis. Either we are dealing with a normal XX karyotype, so there is primary ovarian insufficiency, whether autoimmune or iatrogenic induced, or we are dealing with XO, Turner syndrome, or we are dealing with XY, that is disorder of sex development. If the FSH is not high, you need to repeat it for confirmation. If it was extremely low and your assay is so sensitive to detect this, then you could be dealing with either constitutional delay or a congenital hypogonadotropic hypogonadism. Those two syndromes, they're so close to each other that makes them difficult to be distinguished. If the FSH was just lowish, so we could be dealing with the functional hypogonadotropic hypogonadism, as we said, excess dieting, exercising, or sickness, or any anatomical reasons that is obstructing the outflow, or any list of the causes that cause secondary amenorrhea. The other diagram, if the uterus is absent, then as we said, again, we need for the karyotyping and testosterone level. So if we are having a normal karyotype XX, then we're dealing with a congenital defect in the formation of the Mullerian structures. When we say Mullerian, we are referring to the fallopian tube, uterus, cervix, and part of the vagina. So there is defect, and these structures did not form. They'll be having normal FSH, normal hormone, normal development, except that this internal genitalia structures did not form. Or with absent uterus, we could be dealing with XY, that is a disorder of sex development. So if we go back to this case, that investigation list that was done in 2018, we can see the FSH 151 repeated. It confirmed to be in the menopause range and with a very low estradiol, and the rest of the secondary workup, including the androgen profile, pregnancy test, all were unremarkable. So basically, we're dealing with primary amenorrhea. Seems to be at level of gonadal failure, with given her history of leukemia and chemotherapy. It seems secondary to the potent chemotherapy that she received. So if we go into details into her background, leukemia was diagnosed 2015, received chemotherapy, went into remission the year after. Then she went into stem cell transplant in 2016 in Korea. Her transplant course was complicated by graft versus host disease involving two organs, that is the liver and the lung. The rest of the workup was unremarkable, and since her FSH is high, we said this is an indication to do karyotyping. So karyotyping always involves 20 cells to be analyzed, and surprisingly, we found that her karyotype was 46XY, and this was confirmed by an additional staining. So we received the genetic lab report that this is a 46XY disorder of sex development. So the other major investigation that should be done, we said biochemically FSH, radiologically ultrasound pelvis. So here you can see the uterus. She had a uterus, measures 4.6 by maximum diameter. Cervix is present. Both adnexia showed small structures look like ovary. 12 millimeter by 14 millimeter. So if you look at the uterus size, usually adult size uterus reaches up to 9 and 10 centimeters. So this is an infantile uterus, and the small structures that is likely to be an ovary measures 12 millimeter maximum diameter. Usually the ovary can reach up to 5 centimeters. So this is a shrunken ovary. The finding was confirmed by the MRI pelvis. So the follow-up by the endocrine service that this is primary amenorrhea secondary to disorder of sex development, and it was planned to discuss the case in MDT with the gynae and the genetist for future plan, and for now to continue the hormone replacement therapy, and to discuss with the father later the plan of the NDT, and to discuss with the patient whether to offer her to continue her life as female and to advise to go for gonadectomy. So the questions that raised that should this patient be offered at this time now gender selection, number one. Number two, is gonadectomy required? Number three, what age should the patient go for the gonadectomy? Okay, so to address these questions, we have to know which 46XYDST we're dealing with. So we have 8 syndromes. One is the complete gonadal dysgenesis, second, partial gonadal dysgenesis. Then we have the testicular regression syndrome, disorders of androgen synthesis. When we say androgen synthesis, we are referring to enzymatic defect, disorder of androgen action. When we say action, we are referring to receptor defect, or this is an LH receptor defect syndrome, or we're having disorder in the anti-Müllerian hormone, or this is an ovotesticular disease. So let's go through these disorders. Let's start with the first one, complete gonadal dysgenesis. As the term refers, complete gonadal dysgenesis, it means just streak of gonads that's left over. So these streaks of gonads, that's the testosterone. Now, the testosterone produces 2 important hormones. One, the testosterone. One is the testosterone, and the other hormone is the anti-Müllerian hormone. The testosterone is in charge of forming the internal and external genitalia. The anti-Müllerian hormone is in charge of arresting the formation of the Müllerian structures, the female structures. So when we have a streak of gonads that's neither producing the testosterone nor producing the anti-Müllerian hormone, so we are having by default an internal genitalia of female. There are no testosterone to form the Wolffian structures. So it seems that syndrome number 1 matching our case. How do it look biochemically? Biochemically, they will be having a hypergonadotropic hypogonadism, same profile that our patient had, and they advise to go for gonadectomy because the risk of developing occult tumor in this testis is almost 30%, which is high. So later you need to give estradiol to induce breast development, and in societies where donor oocyte is acceptable, pregnancy can be achieved with IVF and donor oocytes. So should we offer gender selection patients with complete gonadal? No, because they are internally, externally, they are female, they have complete female body habitus, and the testosterone, the testis is not functional, it's useless. So you have to just reinforce the female gender identity in such cases. Let's go to the second syndrome. That's the partial gonadal dysgenesis. I will not spend time on this. It's same as complete, but since the word says partial, so there is some testosterone production, some anti-Müllerian hormone production. So wide variation, the picture could be present, depends on how much the amount that testis is producing. Let's move to the third syndrome. That's the testicular regression syndrome. So it's also called testis vanishing syndrome. It's thought that the embryo had a normal testis during his life, and at certain point, for some catastrophic event, it vanished. So this vanishing could happen so early in the pregnancy, or it can happen very late in the pregnancy. So if it happened toward the end of the pregnancy, then the embryo has been exposed to a good amount and duration to the testosterone, so they will be having both internal and external genitalia virilized, and the Müllerian structures will not form. They will have all the male Wolffian structures. When I say Wolffian, Wolffian means the epididymis, the vas deferens, and the seminal vesicles. And however, the testis will be vanished at time of birth. However, if it occurred early, then the picture would be incomplete masculinizations. The fourth syndrome, that is the disorder of androgen synthesis. So androgen synthesis, we are referring to enzymatic defect. Usually, enzymatic defect impairs the virilization of the external genitalia to a greater extent than the internal genitalia. These are the list of the enzymatic defects. I'll be speaking about the 5-alpha reductase. And it's an autosomal recessive disease. In 5-alpha reductase, the problem is that the testosterone is not converted to this one, dihydrotestosterone. Dihydrotestosterone is a very potent androgen for the virilizations of the external genitalia. So this will lead to the either classically will look like will have a female external female genitalia, or sometimes ambiguous genitalia presenting with severe perineal hypoespadia, where you will find the phallus midway between penis and clitoris, and the urethral opening is not at the phallus, it's at the perineum, and the urogenital sinus will be open, mimicking a shallow vagina, and there will be a cord that is tethering the phallus to the perineum. Let's also in 5-alpha reductase deficiency, the testis will have impaired spermatogenesis, and if it was classical, they will be raised as female, and at time of adolescence, when there will be a surge of testosterone, this is the time they will show the virilization signs. So how to diagnose 5-alpha reductase? The ratio of testosterone to dihydrotestosterone will be elevated 10 times in infants and 20 times in older kids. Sometimes in prepubertal, basal 1 is not enough for diagnosis, so people do the HCG stimulation for better diagnosis. The management of 5-alpha reductase is very complex. If the patients, when reach adolescence, they are preferring to continue to be raised as female, then you should go for gonadectomy. 1, to prevent further fertilization. Number 2, to develop the development of any tumor in the crypticoid testis. And then the external genitalia needs some corrections, and later continue the estrogen to maintain the feminizations. In case the affected patient decided to go for a male gender, then again the management is not easy. So you need first here you should not remove the gonads. You should just correct the cryptorchidism, and the external genitalia, including the urethra, should be corrected. For sperm, since 5-alpha reductase have impaired spermatogenesis, they can go for advanced pregnancy options with IVF, ICSI, or intrauterine insemination. Now, the second syndrome, I'm not going to spend time on it because those present with hypertension, hypokalemia, so I'll skip this one. I'll move to the receptor defect. That is the androgen insensitivity syndrome. The receptor mutation, there is more than 400 different receptor mutations. So if you did genetic test for a receptor mutation, you found negative, this does not rule it out. And the reason, because we have more than 400 different types. Previously, it was called testicular feminizations. Now it's called androgen insensitivity syndrome. There are 4 phenotypes in androgen insensitivity. The presentation depends on the severity of the mutation. Sometimes the androgen receptor could be entirely absent. Sometimes the androgen receptor is present but abnormal in function, or sometimes the androgen receptor is present and normal but reduced in quantity. And therefore, we have these phenotypes, either complete androgen insensitivity, or a partial androgen insensitivity, or Riekenstein syndrome. Riekenstein syndrome, we are referring to a male who is under-virilized, or just an infertile male. He doesn't have any issue except fertility. So in complete androgen insensitivity, I have to refer to the scientist Morris, who first discovered this syndrome in Yale University, and he initially named it as testicular feminization. It's an X-linked recessive disease, but sometimes de novo mutations do occur. So in complete androgen insensitivity, the receptor is mutated, not sensitive to the testosterone receptor. So the Wolffian structures, the male Wolffian structures, will not form. And the external genitalia would look like a female. However, will they be having the Mullerian structures that the female? Yes, they will be having the Mullerian structures, and they'll be having a female body habitus, and they will be having a female breast, even enhanced female breast, and because of the aromatization of the excess testosterone that is not binding to the receptor to estrogen. So biochemically, they will be having a testosterone male level, LH high, because the tissues are not sensitive to the testosterone, and even the estrogen, because of the aromatization, will be high. So the clinical management in complete, the one that look completely like female, it's better to go for gonadectomy when the puberty is achieved, like around age of 16 and 18 years, and then you continue with the estrogen replacement therapy. Now, for all these 46XY DST syndromes, always psychological support should be there. And in this scenario, the female gender identity should be reinforced. Does it match our case scenario? No, because here in complete androgen sensitivity syndrome, we don't have the Wolffian structures, plus we don't have the female Mullerian structure, so it doesn't match. Now, the other types of androgen sensitivity, the mutation is less severe, so there will be a very wide variation from female who's virilized to a male who is under-virilized, who might be infertile. So the same applies for the complete partial androgen insensitivity syndrome. Riefenstein, as we said, it's a male, but he is under-virilized, and sometimes they have problem with the external genitalia appearance, where they have a bifid scrotum and the urethra is placed at the perineum instead of the urethra. If they are bothered by they might have breast development. If they're bothered, they should go for mastectomy. Okay, so the biochemical profile mimics, they are all the same. So in summary, the androgen sensitivity syndrome, we have the 4 phenotypes. What's the important thing to be considered when assigning the gender is the experts' review for the case, and to decide by looking at the size of the phallus and the feasibility of constructing the penile urethra. Is it feasible or no? Then, after the review of the expert, to decide whether to go for better gender, male or female. Now let's move to the LH receptor defect. It's an autosomal recessive disease. So what's LH receptor defect? The Leydig cell, the testosterone have Leydig cell and Sertoli cell. The Leydig cell is in charge of producing the testosterone. The Sertoli is in charge of producing the anti-Mullerian hormone. So the Leydig cell is hypoplastic, so there is no production of testosterone or very little. Therefore, the Wolffian structures, male internal Wolffian structures will not form. However, the Mullerian structures also will be arrested, and the reason that the Sertoli cell in the testis is still functional, so it will produce the anti-Mullerian hormone that will arrest the formation of Mullerian female structures, that's the fallopian, uterus, cervix, vagina. Biochemically, they have low testosterone because the Leydig cell is hypoplastic, and because of the feedback, the LH would be high. Let's move to the before last, the disorder of in the anti-Mullerian hormone. It's also called the hernia uterine inguinal syndrome. It's also autosomal recessive. So because there is defect in anti-Mullerian or its receptor, so the Mullerian structures will continue to form because the anti-Mullerian hormone is not functional. It will continue to form. So the testis is producing testosterone will form the Wolffian male structures, and the anti-Mullerian hormone is not functional, the one that is produced by this testis. So the Mullerian structures will continue to form. They will be having double internal genitalia. One is male and one is female. But it will present like a hernia. The last disorder, the ovotesticular disorder, most of the time it happens in XX karyotype, but you can see it in XY karyotype, where they have both gonads, the ovo and the testis. It could be unilateral or bilateral, and they have both Mullerian and Wolffian structures. And depending on which of those is overwhelming, the genitalia will look like. So which of those disorders fit our patient's presentation? It seems the first one, the complete gonadal dysgenesis, where internally and externally the patient have female genitalia structures. And should we go for gonadectomy? If it was this scenario, then the risk of occult tumor in such syndrome is 30%, so it's high, yes. And should we offer patient gender selection? No, they are internally, externally have female genitalia, and in societies where they accept the oocyte donor, they go into pregnancy. So just please reinforce the female gender identity. So we went back to the past history of these patients, and we found that part of the prognostic investigations for leukemia that was done, it was FISH, and at that time revealed XX karyotype. So the question, can transplant from a different gender affect the original one? Later in 2020, unfortunately, this patient had relapse of the leukemia, and she reverted back within 5 years. She reverted back her karyotype. Now, just let's go quickly through the endocrinopathies that is affected after the stem cell transplant. The endocrine system is the system #1 that is affected. The gonadal damage in females almost 99%, and in men 60 to 90%. If we look at the risk factors that make one person more susceptible to damage to the other in stem cell transplant, if the transplant was post-pubertal, they are more sensitive than pre-pubertal. The more the advanced the age, they are more sensitive to the damage. Female gender, more risk for gonadal damage than male. Underlying disease, leukemia and lymphoma, since they receive a very high risk protocol chemotherapy, they are at risk. Treatment-related factors, like if they received total body irradiation, pelvic irradiation, alkylating agents, chemotherapy like busulfan is very toxic to the gonads, or if they had graft versus host disease, they are also at risk of damaging their gonads. So are there reported cases similar to ours of amenorrhea presenting post-bone marrow transplant misdiagnosed as DST? Yes, so this case was reported in 2016 in China. Similar to our presentation, diagnosed to have leukemia. She had 46XY karyotype with a menopausal FSH range, and she had again of minimal PV bleeding. This just reinforced that the importance of collecting a very comprehensive collection of the history helps you in making and in working up the diagnosis. So if you remember, in our case scenario, the father reported a possible remote minimal PV bleeding before his daughter gets sick with acute leukemia. Case #2, this was reported in Tunisia. It was a secondary amenorrhea that happened after bone marrow transplant. And most of the case scenarios that I found in the literature, the leukemia was the transplant, because the only curative treatment in leukemias is the transplant. So the cases who had gender mismatch and presented as misdiagnosed as DST. Case #3, this is also in Tunisia, sex mismatch after stem cell transplant. So same scenario, she had a lymphoblastic leukemia, menarche at age 12. Again, they did the chromosome analysis. It was 46XY. In this scenario, she presented as primary amenorrhea. They did not have a background of her karyotype, but they figured out the original karyotype of the patient when they went for skin fibroblasts, not blood. The blood gave them the 46XY, the skin fibroblast gave them the embryonic karyotype of this patient. So definitely the hematocyte is affected after the transplant. However, the somatic and the germ cells, they are less likely to be affected. This case, another case.
Left.
Yeah, okay. It was reported in China. Same scenario, but it was aplastic anemia. They used the forensic medicine, and the original karyotype was diagnosed from the hair karyotype. The last case in Romania, so again, it was leukemia, and the correct diagnosis was reached by the swab of the mucosa, of the cheek of the mucosa. So this is to reinforce that hematocyte will misdiagnose the original karyotype, so go for somatic or germ cell tumors. So this is my last slide, my take-home message, that when you're having primary amenorrhea with a karyotype XY, please don't forget that one of the differential diagnoses could be gender mismatch stem cell transplant. Okay, so the mic is back to yours, Dr. Raya. I'm done with my presentation.
Thank you so much, Bidur, for this elegant presentation and interesting case. Now we will move to the third presentation for the sake of time. So the third presentation is about clinical peers and prescribing oral contraceptive pills. And our presenter today is Dr. Kinda Al-Ani, who is consultant obstetric and gynecologist in Dubai Hospital. Dr. Kinda is the associate professor in the academic department of Dubai Medical College for Girls, and she is a member of the scientific committee of Emirates Endometriosis League in Dubai. Her area of interest include obstetric medicine and early pregnancy assessment, where she leads or in charge of both units in Dubai Hospital. Also, she is interested in advanced hysteroscopy surgery and colposcopy. Dr. Kinda, thank you very much for being with us, and you can share your presentation.
Thank you very much for the introduction. Sorry, I'm just trying to share. Just want to check if you can see my screen, Dr. Araya.
We can. Yes, we can.
Yes, thank you very much. So I'm going to put some light on a very important subject, which is prescribing contraceptive pills, and we can see this in our daily practice. I have nothing to disclose. My objective of this presentation will be aiming on using the pill for contraceptive benefit and its non-contraceptive benefits. The types of the contraceptive pills, which are combined contraceptive, the Progesterone-Only pills, and the emergency contraception. The component of each type with their side effects, the usage regimen, and the ideal and typical users with a failure rate. When I counsel my patients about contraception, I always start with this statement that the only 100% effective, safe way to prevent pregnancy is abstinence from sexual activity. Otherwise, any other method can fail. The least effective methods are the condoms, withdrawal method, and spermicide. And the most effective ones are permanent sterilization for male and female. Some reversible contraception are very effective, like having the intrauterine device and the implant. Lies in the middle, oral contraceptive pills, the patches, rings, and injections. Every woman who has contraceptive advice should know how well does the birth control given to her work. So we should always explain how does it work, for how many years, or how we prescribe it, and the failure rate. So if we talk in general, like having the implant, IUDs, the normal one, the Mirena, and even sterilization, they all work very well, and they have a hassle-free time zone, and the chance of them of the pregnant patient getting pregnant will be less than 1 in 100. When we talk about other contraception, like being on the pill, patches, rings, and depot injection, they work well with different way of using it, and the chance will be between 6 and 9 per 100, of course, depending on the use. Some other methods don't work very well, like withdrawal, using the diaphragm, or maybe checking ovulation, and the condoms, where failure rate lies between 12 to 24 per 100 women. Of course, always here remember condoms are protective from STDs, and they can be used with any other methods of contraception. When we talk about hormonal contraception, which is my main subject for today, we should always understand that they are reversible methods, and once we discontinue treatment, it goes back to normal. They have lower failure rate compared to other methods. They are safe in healthy women, very convenient to use, low cost, easy and simple, and readily available. Women always worried about the hormones components in the contraceptive pills. For those, we always should tell them that the risk of them getting pregnant with the pregnancy hormone changes is far greater than the risk associated with hormonal contraception. And hormonal contraceptives are among the very effective contraception options. Added to their benefits of the contraception is the non-contraceptive benefits, which I will be talking about later. Our 3 types of oral contraception are the combined, the mini pills, and the emergency contraception. Starting with the combined oral contraceptives, they are very widely used in North America and Europe. They are very efficacious, 99.7 with the perfect use, 92 with the typical use. They are safe, and they can rarely cause serious complications like DVT and PE. They have a few persistent intolerable side effects. They have also few absolute contraindications, but for healthy non-smoking women, they can be continued until the age of menopause, and they have the advantage, as I said, with other non-contraceptive benefits. They contain estrogen in the form of ethinyl estradiol, and progesterone, which can be one of a dozen different progestins. They can be administered in 2 regimens, either 21/7 regimen or 21/4 or 24/4. In the 21/7, 1 tablet each day for 21 days, followed by 7-day pill period. In 24/4 regimen, 1 tablet for 24 days, followed by 4-day pill period free. In this regimen, there is increased efficacy with lower estrogen content as a whole in the same month, and decreased hormone withdrawal side effects during the shorter 4-day hormone pill free. Of course, some brands, you can see that they have 28 tablets in the sachet. These tablets are hormonal free and placebo tablets. How do they work? They work as a strong anti-gonadotrophic where they lead to inhibition of ovulation. Estrogen is reducing the FSH, progesterone acts on LH. Both hormones will help to inhibit LH surge at mid-cycle, which will stop the ovulation. They can cause thickening of cervical mucus, which inhibits sperm penetration, and they make the endometrium unsuitable for implantation. Now, estrogen component of combined oral contraceptive pills is, as we said, ethinyl estradiol. It differs between brands and has been reduced to improve tolerability of the pill. It is available in 20, 25, 30, 35, and 50 micrograms of the ethinyl estradiol formula. And the lower the dose, the lower the risk. It makes sense that we start with a lower dose, like 20 micrograms, but if the patient has unscheduled bleeding, then we can increase the dose or titrate the dose up. Women who would like the combined contraceptive pills only for contraception, they should be prescribed up to 35 micrograms. So 35 or less, please, if you want to use it for contraception. The combined pills containing 50 micrograms should not be generally considered for contraception, but they can be given only for acute management of abnormal uterine bleeding. Now, the progestin component of the combined oral contraceptive pills makes all combined pills as anti-androgenic. The fourth generation of progestin has strong anti-androgenic properties, and it differs from the 19 norprogesterone by having a cyanomethyl group rather than the ethanyl group at the 17 alpha position. Certain types of progestins have more potent anti-androgenic properties, and they are more effective in treating acne, hirsutism, polycystic ovary syndrome. Of course, these types, they have a slightly increased risk of VTE, especially gestogene, desogestrel, and drospirenone compared to levonorgestrel. Combined pills can be either monophasic or multiphasic. In monophasic tablets, there are fixed amounts of estrogen and progesterone in each tablet. Multiphasic can be biphasic and triphasic, where varying amounts of the two hormones according to the stage of the cycle. So the difference between the three types, monophasic have even levels of estrogen and progesterone in provided throughout the cycle, like 21 days. So each tablet is the same in the pack. Biphasic have static estrogen level, but two different progestin rates, which switch at mid-cycle. Triphasic have varying estrogen and progesterone level throughout 21 days of the cycle, or 24 days as in other brands. Triphasic contain ethinyl estradiol ranging between 25 to 40, and one of several progestin in doses between 0.05 to 1 milligrams per day, which are substantially lower dose if you talk about the total dose of hormones in each month than that of the monophasic tablets. The triphasics are highly efficacious. Monophasic combined pills preferred as the initial prescription because of the ease of its use by patient with the consistent hormone dose in each tablet. So if she misses one of the tablets, she can take another one. It doesn't matter which one of the pack because they are all the same. While multiphasic combined pills require more careful adherence to specific sequential order in which to take the pill each cycle. They provide better cycle control, and they have less side effects than the monophasic. The only problem with it is that they cannot achieve extended cycle withdrawal bleeding in the same way that the monophasic pills can. So if the patient wants to postpone her periods or have continuous use of the pill, do not prescribe the multiphasics because they don't work. The patient will have some bleeding at the time of her menstruation. Changing hormone levels in multiphasic combined pills could exacerbate mood symptoms in susceptible women like those with PMS. If we want to touch on the non-contraceptive benefits of the oral contraceptive pills, we have so many to say about. Basically, the pill will cause regular, painless light period. So it can be used for regulation of menstrual bleeding disorder. It can cause reduction of menorrhagia with improvement of resulting iron deficiency anemia. It can treat dysmenorrhea. It can cause reduction in the pelvic pain related to endometriosis, adenomyosis, and it can cause, it can improve acne. It can reduce hirsutism. It can cause reduction of symptoms of premenstrual syndrome. It can reduce postmenopausal hip fracture risk in women who used it in their 40s, around the perimenopausal. And the continuous use of contraceptive pills or extended cycle can reduce symptoms of menstrual migraine. More of these benefits that there is less chance of developing a new ovarian cyst, they can because of the suppression of ovulation, but they have no effects on existing ovarian cysts. So patients having existing ovarian cysts, please do not prescribe the combined pills because they will not work. It may only regulate the cycle if it become irregular while the patient having this ovarian cyst, but it will not work on an existing cyst. This is one of the myths that we see it in our practice. It can cause low incidence of fibrocystic benign breast disease, reduction in endometrial cancer due to the progesterogenic effect, reduction in ovarian cancer, possibly due to inhibition of ovarian stimulation, and reduction in colorectal cancer, as studies have shown in current users of the pill. Now, if this is a nice graph to show the relative risk for breast cancer among non-users, and these are the one who used it. So if we say the relative risk is 1 for non-user, it increased to 1.24 if with the current use of combined pill, and 4 to 4 years after stopping the pill, that risk will go down to 1.16. After 5 to 9 years from stopping the pill, it will go to 1.07, still higher than the non-users. And after 10 years, it will go to 1.01, again, higher or just above the non-users. If we talk about the cancer risk with the pill, there are 2 cancers that they can increase with using the pill. Breast cancer, because of the hormonal effects. It increase straight after starting the pill, and it will up to 10 years, it will be the same. Cervical cancer increased dramatically after starting the pill, but the way for why cervical cancer increased is not because of the hormones present in the pill. It's because these patients who start using the pill are not using other methods, barrier methods, which usually protective against cervical cancer. However, after stopping the coming of the pill, breast cancer risk after 10 years will be as the same as the non-users. Cervical cancer will go even lower than the non-users. The protective risk will be for ovarian cancer, which will be lowered by half, and the endometrial cancer, the risk will be at its max after 10 years of the pill users, and it will increase back a little bit up, but will be less than the non-users, and actually, so it has a protective benefit. Always we worry about VTE risk with the combined contraceptive pills, but we should all think that the risk of DVT considerably lower than that while being on the pill, lower than that if patients get pregnant or during her pregnancy or in the early postpartum period, where the relative risk is 0.2 per 100 years. While the rate of VTE anyway is very low in young women, the absolute risk of VTE in combined users approximately 0.06 per 100 years. The absolute risk is higher among women with associated conditions such as thrombophilia, smoking, obesity, polycystic ovaries, older age, and immobilization. The risk is greater in the first few months of the combined pills use. So please do not advise patients to have breaks of the pill, because some patients which we have seen, they come and they will say that, okay, I want to give my body some rest from the hormones. So she will stop it for a few months, use another method of contraception, go back on the pill. Actually, that will increase her chance of getting VTE, because as we said, after a few months of when she restarts using the pill, the risk is increasing. Here, just to mention about the risk of DVT with obesity. So these are the blue bars are the non-users, the gray are the users. When BMI less than 25, of course, the risk is more anyway being on the pill. But when BMI 25 to 30, the risk is greater. And when BMI is 30, even double the risk compared to lower BMI. So obesity itself may impair the effectiveness of combined contraceptive pills, and also both obesity and the use of the pill are independent risk factor for venous thromboembolism. So we have to be careful when prescribe it to patients with high BMI. Women over age of 35, it is safe to be used in these women as long as they are non-smokers and healthy with no other risk factors. And they may have beneficial effects on bone mineral density and vasomotor symptoms, which they may experience in the perimenopausal age if they were not using the pill. Hypertension, also the pill is associated with the increased risk of hypertension, myocardial infarction, and stroke. Diabetes, combined pill can be used in diabetes, in diabetic patients, as long as they are non-smokers, healthy otherwise from their diabetes, younger than 35, with no evidence of hypertension, nephropathy, retinopathy, or other vascular disease. So again, with caution and selective patients. Smoking can be used with caution if it is the only one in older women than 35 who smoke. So here we have to be very careful and choose and counsel our patients carefully. If now moving to progesterone-only pill, the mini pills, they contain progestin only, either norethindrone or drospirenone, which are the main available ones. They offer an alternative option where to combine pill where estrogen is not contraindicated. They have low dose of a progestin to be taken every day without a break. They have lower efficacy than the combined pills, although this depends on a strict adherence of its usage. And they are less popular in our community than in Europe because of the unfavorable bleeding pattern. How to take the mini pill? We always should advise the patient to take the pill each day at the same time. So we have to be very strict with the time. Once the patient finished the pill, she in the pack, then she has to start again a new pack. Doesn't matter, there is no stopping, even if she has bleeding. Late taking the pill, then she should take it straight as soon as she remembers it. That means sometimes that she will take 2 pills in the same day. That doesn't matter. And she should not be more than 3 hours late. So I always tell the patients, if you are more than 3 hours late, then you will be punished for another 2 days, and then you have to use another method for contraception. So this is the rule, please. If they are more than 3 hours, let them take another precaution for another 2 days. Again, there is one more here issue here, that if usually we start the progesterone-only pill on day 1 of the cycle, but if it is started more than 5 days from the onset of period, then she has to take an extra precaution for 2 days after starting the pill before we can say that it is safe to have sexual activity. How does a progesterone-only pill work? It's only a few hours after taking the pill, there will be a reduction in the cervical mucus, which with increased viscosity, which prevents the sperm permeation into the endometrial cavity. These changes persist for 20 hours. And once the tablets are discontinued, fertility returns rapidly. And that's why we always stick to the 3 hours rules of taking the pill. Other mechanism includes slowing movement of the egg through the fallopian tubes and thinning of the endometrium. Now, just to mention here, the difference between the older POPs and the new ones, norethindrone POP doesn't always suppress ovulation. Half of the patients are still ovulating with the pill, but of course the pill will work with other mechanism. Drospirenone progesterone-only pill have the added advantage that they suppress ovulation, and that makes it more effective. Progesterone-only pills has very low side effects, which can be the unscheduled menstrual bleeding. They have increased prevalence of follicular ovarian cysts. They can cause acne flare-up. Mood changes, the data is conflicting, but there was a Danish study which showed that the patients who have just started the progesterone-only pill are at increased risk of using antidepressants, so it can cause some depression. POP do not cause significant weight gain, and they are not likely to increase headache frequency. They have very limited serious complications, perhaps a little effect on the cardiovascular risk. Ectopic pregnancy here, we should emphasize. Ectopic pregnancy overall risk is higher, is lower because it prevents pregnancy inside and outside, but the likelihood of pregnancy is ectopic is higher if the patient is using the progesterone-only pill. Previous history of ectopic does not contraindicate POP. Breast cancer risk, there is no evidence that it's associated with the progesterone-only pills. Here is only to compare the result of the use of thrombosis between combined pill progesterone, but arrhythmias here it doesn't really exist. Emergency contraception, we have levonorgestrel, ulipristal acetate. Levonorgestrel is progesterone with a high dose. Ulipristal acetate is antiprogestin, 30 milligrams. It prevents ovulation if taken pre-ovulatory period. Ulipristal delays ovulation in both pre and post LH surge. which makes it more efficient than levonorgestrel. This can be taken up to 3 days. This can be taken up to 5 days. In emergency contraception, however, we should take it patients should take it as soon as possible, preferably in the first 12 hours. Both levonorgestrel and UPA do not prevent ovulation if it's taken on the day of LH peak. So they cannot prevent implantation as well. So they can prevent or delay ovulation, but not on the day of LH peak. The efficacy depends on the time of its use. So none of these drugs interfere with implantation or fertilized egg, or if already established pregnancy. They should not cause abortion or used to induce abortion, and they are not meant to be taken regularly. Here, only just to let you know that there are other types of emergency contraception, like using the pill with combined pill with high doses, and intrauterine device up to 5 days, both, but they are not approved by FDA. The only approved one over the counter is the Progesterone-Only pill, Levonel, and the upiracil acetate up to 5 days. Thank you very much for your attention.
Thank you very much, Dr. Kinda, for your excellent presentation. And now I invite all the speakers for the Q&A session. Since we are a bit late, hopefully we'll have 10 minutes and we'll be able to address most of these questions. So I will start with you first, Dr. Asma. There is a question regarding the duration of using the OCP in a patient with PCOS. So is there a time limit, or the patient can use it for years? And maybe Dr. Kinda also, you can add on this later.
So in the beginning, you can use it for 6 to 9 months with the patient, see how the patient is responding to this. Then it's going to be based on patient symptoms and what they want in their future. Are they aiming for pregnancy? They're aiming to only regulate the cycle. If they only want to regulate the cycle, so you have to continue for at least in the beginning 6 to 9 months. Then at the same time, I'm sure that the patients will be asked to use another lifestyle modification to see if that would help also in their weight reduction and improving their ovulation. Then you're going to give them a gap after that and reassess their cycle without the OCP. For also, if you're targeting hyperandrogenism, you're going to continue when see the patient response to that. Then the minimum is 6 to 9 months duration of treatment. I don't know about you, Dr. Kinda, what do you think?
Yes, I agree with you totally, really, yeah.
Excellent. Dr. Abdur, there is a question in regard if there is any relation between DSD and development of leukemia, as in your case.
Okay, so my case, it's in fact the other way around, where the initial diagnosis was leukemia, that the chemotherapy led to a primary amenorrhea, the gender mismatch lead to the change in the hematocyte karyotype. So no, the primary amenorrhea should not lead to the other way, leukemia. However, if you mean by the questions that if the original karyotype have reverted back within 5 years, the patient lost the donor karyotype and she reverted back to her original type, is this a poor prognostic marker? In fact, while I was preparing my case, I tried, because it came to my mind, I tried to dig in the literature to see if this is a poor prognostic markers, because in leukemias, they use cytogenetic analysis for such. I could not find an answer for this question.
Interesting. Actually, we have similar case to your case, the same thing. So in these cases, we should use maybe the buccal rather than looking for the
somatic cells are not are the least to be affected by the transplant.
Exactly. Then, Dr. Kinda, there is a question regarding is oral contraceptive a valid option as a replacement therapy in women with ovarian insufficiency, I mean, as HRT? So this is a very good question. It is something we counter it a lot.
Actually, if we wanted only to replace hormones, it's better not to use the contraceptive pills with a high doses of estrogen as for ovarian insufficiency, because the ovaries will if they were working, they will produce less amount of hormones rather than the one given by the combined contraceptive pill. So in this case, I will go to HRT or a bit higher dose like progesterone when it's not a contraceptive in a contraceptive amount of hormones, but enough to give the patient with ovarian insufficiency all what she needs for her skin level, for her sexual activity, for bone supplements and everything.
Yeah. So basically, if it is just for the purpose of replacement, OCP will be over replacement.
Yes, yes,
okay.
Definitely.
Excellent. Then another question here for you, Dr. Asma, regarding obese patient with hyperandrogenism, but no oligoamenorrhea or amenorrhea. So no irregular cycles, only hyperandrogenism. After excluding other causes of hyperandrogenism, can we label the patient as PCOS? I mean, the question may be how to differentiate between PCOS and obesity-related hyperandrogenism.
Obesity is not part of the criteria to diagnose patients with PCOS, and we know that we're having lean patients with PCOS or obese patients with the PCOS. So obesity per se is not part of the criteria, but we made sure that the patient is having a regular cycle. Maybe the patient is having anovulatory menstruation, and I need first to make sure that we're doing the mid-luteal progesterone level to make sure that the patient is having really an ovulatory cycle before labeling her that she's having a regular normal cycle. It could be still that the patient is having PCOS if we found that, but if we clearly excluded a regular cycle, we cannot label the patient as having PCOS based only on hyperandrogenism and obesity.
So, Badur, the question, is there any medication that can be used to preserve ovarian function during bone marrow transplant in women? This is for adult women post-puberty who may be planning pregnancy in the future.
Okay. So it's a very interesting question, and it's a big topic to be answered to these questions. So basically, there are multiple things that can be done to preserve and protect the ovary from the gonadotoxicity. One that is used in autoimmune disorders and some malignancies is that they are using the gene-rich analog to suppress the pituitary gonadal axis. So by this, they are keeping it in a silent phase, that hoping to become less being exposed less to the effect of the chemotherapy, and it is one of the successful ways. One other method that can be used in adult and pubertal is by the gonadal stimulations, like the one when they go for advanced pregnancy options. This is, but the disadvantage of this one, that if patient is in a hurry for the chemotherapy treatment, it takes time, so it's not good if they are in hurry in chemo. The third one is an investigational one. It's used in large institutions where they practice this, where they do ovarian tissue banking. They remove a big chunk of the cortex of the ovary, they freeze it, and then they use it in future. The good thing about this is that it doesn't need any stimulation. So just laparoscopically done, and they preserve the cortex of the ovary.
And then they reimplant it later.
Reimplant it, yeah. But this is investigational, so it's not practiced everywhere.
Excellent. Dr. Akinda, there is a question regarding the best or what is your choice of OCP in patient with PCOS?
Actually, it depends on why do we want to use the OCP. Is it for contraception? Then I will give a lower dose possible. If I want it for acne, then I will give Diane for hirsutism and acne. So it depends on actually why do we need to treat it. Same as Dr. Asma mentioned, we should target the problem that the patient is coming with PCOS. So it depends on why does she want the pill for.
Just a question, Dr. Kinda, sometimes we really face with the OCP, some patients, they will have mood changes, which we attribute it to the progesterone component, if I'm correct. So do the bucket specify in your presentation, you said the multiphasic are the one most likely to be associated with the mood changes. So, so in the buckets, we can see if it is monophasic or biphasic or triphasic, or it will not show.
Each pack, of course, depends on the level of estrogen and progesterone. So if you want to minimize it, then you go for the monophasic one. But the components are actually more of estrogen and progesterone rather than biphasic and triphasic.
Excellent. Then I think we are running off time. Thank you very much for your presentation and for the contribution. We hope to see you in future meetings. Thanks a lot.
Thank you, Dr. Raya.
Thank you.
Thank you very much.
So now we will move to the presentation sponsored by Servier, which will be about sulfonylurea in the current practice of type 2 diabetes management, consensus from the GCC Country Advisory Board. And the session will be presented by Dr. Khadija Habib. Dr. Khadija is a consultant physician in the Department of Internal Medicine Diabetes Unit, Rashid Hospital, Dubai Health Authority. She is associate professor and clinical tutor in Dubai Medical College, and her research interests include cardiovascular complication in diabetes and obesity, and she is very well known for her great presentations. Welcome, Dr. Khadija, and the screen is yours. You can share your presentation.
Assalamu alaikum and good evening, everyone. It's a pleasure to be with you this evening. And I'd like to take the opportunity first to thank the organizers for inviting me here. I hope you're able to see my slides.
Yes, we are.
Okay, excellent. Right. So shifting gears slightly from reproductive endocrinology back to diabetes. And the focus of my talk will be to highlight the continuing role of sulfonylureas in clinical practice. And I will highlight the rationale for having a GCC consensus guideline for the use of sulfonylureas. So before we begin, here are my disclosures. And the outline of my talk will really be to remind ourselves on how to apply the best practice in diabetes care. I am going to highlight the long-term efficacy and safety of sulfonylureas, and then I'm going to take you through the results of the clinical practice research data link study, and then highlight this rationale for having a consensus guideline. So the caption on the latest edition of the IDF Atlas, which is the 10th edition that was released just a few months ago, says that diabetes is really spiraling out of control. And we would agree with this because we now have over 500 million people living with diabetes. And unfortunately, the projections for the coming years are all in the northern trajectory. So when we're looking at patients and managing our patients with type 2 diabetes, the overriding goals of care are to prevent complications and optimize their quality of life. So how can we do this? We do this first by assessing the key patient characteristics, and this includes looking at whether they've got established atherosclerotic cardiovascular disease, whether they've got history of heart failure, CKD, and we look at the hypoglycemia risk as well. But we also need to consider other specific factors which may impact on the choice of therapy, and cost there is a major issue. We like to make sure that we can create a management plan which is shared with the patient. The patient's got to agree on that plan. Once we implement it, we need to have ongoing monitoring and support for the patient. And of course, that plan is usually reviewed on a periodic basis. So we also appreciate that when we are managing patients with diabetes, and see whether we can move the slides. Yeah, the management of type 2 diabetes, prevention of the microvascular complications, we know is driven mainly by the hemoglobin A1C, regardless of the treatment regimen. Whereas when we're looking at prevention of cardiovascular disease, this is driven mainly by the treatment regimen more than the hemoglobin A1C reduction. So then when we dip into our toolbox, we have a number of agents, both oral and injectable, and these agents are designed so that they can target the number of pathophysiological defects that define type 2 diabetes. We'd like to use them in a complementary way so that we can optimize a patient's glycemic control and improve their outcomes. So we know that patients with type 2 diabetes, it's a progressive disease. They will require to have drugs in combination. We like to use drugs that can complement each other so that they can target the pathogenic abnormalities. And most importantly, we want to be able to start treatment early and intensify early so that we can prevent or slow down the decline in beta cell function. And so it's very important that we do not fall into the trap of clinical inertia. So let's look at the guidelines, and I will quote our own local guidelines. These are the Emirates Diabetes and Endocrine Society guidelines that were published just last year on the management of type 2 diabetes. And when it comes to pharmacotherapy, the EDS recommends that we take a risk-based approach, looking at a patient's inherent cardiovascular, renal, and hypoglycemia and weight risks as well. The treatment algorithms are really based on the cardiovascular risk, and this is adapted from the European Society of Cardiology and the European Association of the Study of Diabetes guidelines. So let's look at what those parent guidelines say. The selection of glucose-lowering medications should be guided by several factors, of which the presence of atherosclerotic cardiovascular disease, CKD, or heart failure becomes important. We need to consider the need for minimizing weight gain or promote weight loss. We also need to consider minimizing risk for hypoglycemia, but not forgetting that cost is also quite a major issue. So when we look at the new paradigm, we divide the patients into those that got established atherosclerotic cardiovascular disease, heart failure, or CKD. And if that's the case, then the agent that needs to be used has to be one that is proven to have cardiorenal benefit. And so the GLP-1s, receptor agonists, and the SGLT2 inhibitors would fit in there without any debate. On the other side of the algorithm are those patients that do not have established cardiovascular disease or heart failure or CKD or risk factors thereof. And in that paradigm, we think that we would argue that sulfonylureas still have a place. In fact, when we look at large disease registry of patients that we normally see in our clinical practice, just about 30% of those patients will fall into this category, and the majority of them will be those that do not have established cardiovascular disease. And therefore, it's not a surprise that the SUs are still the most prescribed add-on antiglycemic agent, even in large cardiovascular outcome trials such as the EMPEREG and the LEADER. And we know that this is because of their efficacy, their affordability, their flexibility in use, because they can be combined with all the other oral drug classes, except of course the glinides, because they work in the same way. And they can also be combined with insulin in a rational manner. Sulfonylurea is also useful and effective in treating certain moody subtypes, monogenic diabetes. And the subtypes that would be particularly useful are those that have mutations of the HNF1 alpha and the HNF 4-alpha as well respond very well to low-dose sulfonylureas. So what are the concerns? And the skeptics will mention issues around hypoglycemia, cardiovascular safety, and weight gain. So let's look at that evidence. And when we look at the evidence, we can start off by looking at the a model-based meta-analysis of 12 anti-hypoglycemic agents for type 2 diabetes. And what we see in that analysis is that the hemoglobin A1C lowering potential of sulfonylureas is much greater than that of the DPP-4 inhibitors or of pioglitazone. We appreciate that, yes, SUs may be associated with a higher risk of hypoglycemia, but that magnitude of risk is usually due to a variety of factors, including appreciating the pharmacological differences between the agents. So if we look at the risk for hypoglycemia in patients with type 2 diabetes based on their treatment regimen, and here we have data that was derived from a United Kingdom prospective observational study, and they looked at patients that were recording their blood glucose and self-reporting over a year. The incidence of hypoglycemia in relation to insulin was really quite low for the incretin-based therapy, for the sulfonylureas, and for metformin as well. So yes, there was a slightly higher risk for the sulfonylureas, but overall, it was almost comparable to that of the incretin-based therapies. So the other thing that we want to appreciate is that the risk for hypoglycemia is really quite different between the different SUs, with gliclazide giving us the least risk for hypoglycemia. The other situation whereby the risk for hypoglycemia might be accentuated would be during Ramadan. And we have a number of observational studies that have actually shown that gliclazide MR is associated with a lower symptomatic hypoglycemia rate than the other SUs. And we think that this might probably be related to the mechanism of action, and I will show you that. But first, if we look at real-world evidence as well, and this is the Ramadan study that was published last year, it looked at a large cohort of patients in 9 countries. It was aimed at evaluating the safety and efficacy of gliclazide MR during Ramadan fasting. And we can see that there was a very low risk of hypoglycemia during and after Ramadan. And we think that the reduction in the hypoglycemic events, specifically with gliclazide MR, could be explained on the basis of the pharmacokinetic and the pharmacodynamic properties and the mechanism of action. So what is it with the mechanism of action? We know that gliclazide MR is one of the SUs that selectively and reversibly binds to the SUR1 receptors. It does not bind to the SUR2A or 2B, unlike the other SUs. And this may be the explanation of why we see less risk for hypoglycemia. What about the body weight? We know that data and analysis from the advanced trial, from the EASY DIA and the DIA Ramadan studies actually show that there was no body weight gain with those patients that were exposed to gliclazide MR. And in fact, in the DIA Ramadan study, we did see that there were some patients had actually lost about 0.5 kilograms of weight by the end of Ramadan. So here is the data that compares the weight gain with large randomized controlled trials, the VADT, the ACCORD, and the UKPDS, and we can see that in the advance, there was negligible weight gain. What about the cardiovascular safety? And among all the sulfonylureas, we have enough evidence to show that gliclazide MR was associated with the lowest risk of cardiovascular-related mortality, and data comes from both the ADVANCE and the ADVANCE-ON. The ADVANCE was looking at the on-treatment macrovascular events, and ADVANCE-ON was in the follow-up, the 10-year follow-up period. We also have data from the Carolina, which compared linagliptin with glimepiride, and that too showed, if I can show you the Kaplan-Meier curves, they were superimposable. The time to 3-point MACE was comparable between the DPP-4 inhibitor linagliptin and glimepiride. There again, emphasizing that the newer generation sulfonylureas are quite safe when it comes to cardiovascular safety. So the other thing that I would like to highlight is this limitation of using or adopting a cardiocentric approach in the management of type 2 diabetes, because we really need to be thinking about what proportion of our patients that we see in clinical practice are actually eligible for the cardiovascular outcome trials. And then if we look at what is the average proportion of patients that have these macrovascular complications and evidence of CVD, we find that in most diabetes disease registries, they range from about 10 to 30%. And here I have summarized some of those registries. Over the last decade, we have the Improve, Achieve, Discover, and the IDMPS. And if you look at the macrovascular complications in these cohorts and in the disease registries, it ranges from about 12 to 28%. We had the opportunity to participate in both the Discover and the IDMPS disease registries. And I had the privilege of presenting the Middle East and Africa cohort of the Discover trial just last week at the virtual IDF Congress. So we presented a poster which looked at the prevalence and the risk factors for vascular complications in patients with type 2 diabetes. And what we found is that the crude prevalence of microvascular disease was around 18%, whereas that of macrovascular disease was just about 10%. And the commonest microvascular complication that was seen in this cohort was peripheral neuropathy, whereas for macrovascular disease, it was mainly coronary artery disease. So again, if we look at the eligibility of patients in the Discover cohort that would be eligible for entry into the SGLT2 inhibitor CVOTs, we find that it would be a very small proportion of the patients that we normally see in clinical practice. If you remember, patients that were enrolled in the SGLT2 inhibitor trials either had to have established cardiovascular disease or multiple risk factors for cardiovascular disease. And so just about 7% would be eligible of the patients that we see normally in clinical practice. 12% are those with multiple risk factors, and the rest, the majority of them, would not be eligible to those trials. So then we can turn and look at the efficacy and effectiveness. In efficacy, we always get from our randomized controlled trials, we look at how the drug performs under specific controlled conditions, whereas effectiveness is how the drug really performs under everyday clinical practice. And in the perspective of the SUs, we've seen that the newer generation SUs, glimepiride and gliclazide, are quite popular drugs because of their proven safety and their effectiveness. And they're really a cost-effective option for those patients that do not have established atherosclerotic cardiovascular disease. So let me turn your attention now to the clinical practice research data link study. And this study really aimed at comparing, it was a real world study that compared the safety and efficacy of gliclazide MR versus sitagliptin, one of the commonest DPP-4 inhibitors that is used as add-on to metformin monotherapy in patients with type 2 diabetes that were not controlled on metformin. It was a retrospective observational study that was run in the UK that was able to recruit over 1,000 patients with type 2 diabetes that had been treated for almost 9 years. So what did we find from that study is that gliclazide MR, when was compared with sitagliptin, showed that 35% of patients that were on gliclazide could achieve a hemoglobin A1C of less than 7% at 12 months. So I come now to the rationale for the consensus on the guidelines. We know that the prevalence of diabetes in the GCC countries, like the rest of the world, is quite high. In fact, we have a very high prevalence. The use of SUs is quite widespread because of the extensive evidence based on their efficacy. We've been using SUs for over 60 years, and they're quite an affordable option. So the consensus guideline was actually published early this year in diabetes therapy. It was represented by all the members from the GCC countries mentioned here. And then there's endorsement by all the diabetes societies from the respective countries, including the Gulf Association of Endocrinology and Diabetes. And these endorsements are really coming because we've got now evidence from the advance of the long-term safety and efficacy of the SUs. We've also got data on cardiovascular safety here, all-cause mortality, cardiovascular-related mortality lowest with gliclazide. We've got evidence for renal benefits from the advance and the advance on with reduction in microalbuminuria, macroalbuminuria, and end-stage kidney disease. And finally, therefore, I could summarize by reminding the audience that intensification of therapy with a proactive approach is really crucial to achieve target glycemic levels. We need to have combination therapies early in our patients in order to preserve beta cell function. The initiation of combination therapy would actually depend on the individual patient's A1C at entry and their cardiovascular risk. We know that the modern sulfonylureas can be used in both obese and lean patients because of their low risk for hypoglycemia and weight gain. And patients with type 2 diabetes using SU combination therapy wish to fast during Ramadan can do so with appropriate monitoring. And therefore, I just remind everyone that we need to adopt a balanced approach to diabetes management, not being too cardiocentric and not being too glucocentric. And with that, I'd like to thank you all for your attention, and I look forward to taking your questions. Thank you.
Thank you very much, Dr. Khadija. I think for the sake of time, we may take one question.
Okay.
So in case of patient with uncontrolled diabetes, and you will add insulin on top of sulfonylurea, like gliclazide MR. So how is your approach? Dose reduction or remove it, or what you will do?
So you will probably be adding insulin because you want to optimize the patient's glycemic control. I will presume that that patient still has a high hemoglobin A1C, and therefore you've decided to add insulin. If you think that the patient may have a risk of having hypoglycemia, you could reduce this SU dose by 20%. But because you know that the patient's hemoglobin A1C is really quite high, you might want to keep the dose of the SU the same and then titrate your insulin dose slowly, because we know that the combination of the two will really increase your risk for hypoglycemia. But I don't see any need for discontinuing the SU, unless, of course, the patient has other risk factors. Maybe they have underlying renal disease, the kidney function, the EGFR is really low for necessitating the reduction in the SU dose.
So I think there is one question more we will take. Someone is asking about hypoglycemia during sleep. I think their question is the risk of hypoglycemia nocturnal with sulfonylurea.
So we haven't seen much of that, especially with the newer agents such as gliclazide MR. I've not encountered that with my patients, particularly if they're not on combination with the insulin as well. If they're not taking a basal insulin, I'm not usually worried that they will have nocturnal hypoglycemia. However, it is, of course, always useful advice to tell the patients that if they've taken the sulfonylureas, then if they're going to skip their meals or they've skipped their dinner, they could check their readings before they go to sleep. But we haven't seen that being a particular problem in clinical practice.
Excellent. Thank you so much, Dr. Khadija. I wish we have more time, but we are limited with time. Thank you so much.
Thank you.
So thank you everyone for attending this symposium. I would like to remind you that CME will be available in 14 days. You will receive evaluation form to your registered email in order to obtain the CME credits. Also, I would like to remind you all that the recordings of these webinars are available in both EDS Institute website and EDS YouTube channel. You can watch the recordings again, and we encourage all you to visit both the channel and the Institute website. Also, for future upcoming webinars, you can see them in the EDS website. There will be a continuation of the thyroid series that have started already this year and will be continued next year. There are 3 upcoming thyroid webinars on the 11th of March, 25th of March, and 18th of April. And we encourage all you to register and attend these excellent series, which is conducted virtually. Also, we encourage you all to register for the upcoming ADE Endocrine Diabetes Congress, which will be held in February. The registration is open, and we also encourage all to submit your abstract. And it will be virtual as well this year. Thank you so much for attending, and we wish to see you again in future events and symposiums. Thank you.